Atrial septal defect and partial anomalous pulmonary veins. Anatomic description and prevalence. There are multiple locations for interatrial communications, and a detailed understanding of the atrial septal anatomy is needed. Figure 82.8 illustrates various locations of ASDs. The prevalence of ASD is 0.88 per 1000 adults. The most common type of ASD is a secondum ASD, which is a true deficiency in the atrial septum in the region of the fossa ovalis. This should be differentiated from a patent foramen ovale, which is persistence of patency of the flap valve of the fossa ovalis, not associated with right-sided cardiac dilation, and persist in up to 25% of adults. Primum ASDs may be considered in the spectrum of atrioventricular septal defects and involve a deficiency in the region of the atrioventricular valves and are associated with a cleft in the mitral valve. Sinus venosus defects occur in the sinus venosus septum posteriorly to the true atrial septum and usually involve anomalous right-sided pulmonary venous return. Coronary sinus defects, also called unroofed coronary sinus, are rare and involve direct communication of the coronary sinus and the left atrium due to complete or partial unroofing of the coronary sinus and are often accompanied by a persistent left-sided superior vena cava. Patients may also have anomalous pulmonary venous connections not associated with an ASD, known as partial anomalous pulmonary venous connection. PAPVC may be associated with either right or left-sided pulmonary veins, which can have several possible anomalous connections, with the most common being a left upper pulmonary vein to an ascending vertical vein into the brachiocephalic vein or the right upper pulmonary vein draining to the superior vena cava. In the latter case, careful attention should be paid to ensure that there is not an associated sinus venosus defect. When the right-sided pulmonary veins connect to the inferior vena cava, this is called a scimitar vein. Isolated PAPVC involving a single pulmonary vein may cause mild degrees of right heart overload but rarely requires surgical correction. Now, the clinical features. It is not uncommon for adults to have an ASD incidentally discovered at the time of imaging for unrelated issues. Symptoms when they occur most commonly include exercise intolerance, palpitations or dyspnea with exertion. Supraventricular arrhythmias develop by 40 years of age and about 10% of patients and become increasingly prevalent with advancing age. The presence of cyanosis should alert one to the possibility of shunt reversal and Eisenmenger syndrome, or alternatively to a prominent eustachian valve directing the inferior vena cava flow to the left atrium via secondum ASD or sinus venosus defect of the inferior vena caval type. Pulse oximetry at rest and during exercise is recommended for evaluation of adults with unrepaired or repaired ASD with residual shunt to determine the direction and the magnitude of the shunt. The classic physical examination of an ASD is a wide, fixed splitting of the second heart sound, which is due to prolonged RB ejection and increased pulmonary artery capacitance, which in turn delay pulmonary valve closure. Pulmonary flow murmurs are common. The ECG commonly displays a rightward QRS axis and in incomplete or right bundle branch block. The classic chest radiograph features are of cardiomegaly from right atrial and right ventricular enlargement and dilated central pulmonary arteries with pulmonary congestion. Cardiac imaging is essential in determining the anatomy of the atrial septum and pulmonary venous drainage. Transthoracic echo is the initial imaging testing. However, other imaging modalities such as transesophageal echo, cardiac MRI, and cardiac CT may be needed to confirm the anatomy. The 2020 Appropriate Use Criteria guidelines rate these modalities as always appropriate for the evaluation prior to planned surgical repair for sinus venosus defects or for patients with a change in clinical status or new symptoms. The congenital conditions in which high intensity exercise should be avoided, they are cyanosis, high risk coronary anomalies, hypoxemia, severe aortic dilation, severe outflow tract obstruction, severe pulmonary hypertension, severe ventricular dysfunction, ventricular arrhythmias. This list does not include non-adult congenital heart disease, high-risk lesions such as hypertrophic cardiomyopathy, channelopathies, or arrhythmogenic cardiomyopathy. This table shows expected chamber enlargement with cardiac shunts. In ASD, right atrium, right ventricle, and pulmonary artery will be enlarged. In VSD, pulmonary artery, left atrium, and left ventricle will be enlarged. RB may be enlarged. In PDA, pulmonary artery, left atrium, left ventricle, and aorta will be enlarged. Now repair. When an ASD is discovered in an adult, if there is any degree of right heart dilation associated with symptoms, closure should be considered. It is important to verify the direction of the shunt as left to right. The next step is to verify that the PVR is less than 1/3 of the systemic vascular resistance. The pulmonary artery systolic pressure is less than 50% systemic. There is right heart enlargement and the QP/QS ratio is at least 1.5:1. The majority of secondum ASDs may be closed percutaneously. However, surgical closure is required for sinus venosus defects, primum ASD, or coronary sinus septal defects. It is reasonable to close an ASD in an asymptomatic patient with right heart enlargement. AHA-ACC Class 2A recommendation level of evidence C. If invasive hemodynamic assessment confirms significant elevation in pulmonary vascular resistance and/or pulmonary pressure, collaboration between adult congenital heart disease and pulmonary hypertension providers is important. Surgical closure is typically performed using a patch of autologous pericardium or synthetic material with an open sternotomy and cardiopulmonary bypass. The operative mortality is low. However, post-operative complications of post-pericardiotomy syndrome or atrial arrhythmias may occur. Special attention must be paid to those defects with partial anomalous pulmonary venous drainage, as redirecting the pulmonary venous flow may result in pulmonary vein stenosis. In patients with primum ASDs, care must be taken in closing the mitral valve cleft to avoid mitral stenosis or residual regurgitation. Transcatheter closure is now widely accepted as an alternative to surgical repair for the majority of secondum ASDs. Several devices are available and range in size and configuration. Adequate rims of the defect must be demonstrated to ensure safe transcatheter closure. Post-procedural complications include atrial arrhythmias, heart blocks, thrombus formation or the device and rarely device mobilization or erosion. Now, what are the long-term outcomes and complications? Patients who undergo ASD repair prior to the age of 25 years have favorable outcomes. However, surgical repair does not provide proven benefit in reducing arrhythmia burden in older adults. Following closure, patients with significant residual shunt, valvular or ventricular dysfunction, arrhythmias and/or pulmonary hypertension should be followed at regular intervals with transthoracic echo. The imaging recommendations for patients following transcatheter ASD closure are dictated by the specific manufacturer, but in general, transthoracic echo is performed at 1 week, 1 month and then annually for at least 5 years following closure. So, in general, transthoracic echo is performed at 1 week, 1 month and then annually for at least 5 years following closure. Any patient who has had a transcatheter ASD device placed who present with chest pain should have an urgent evaluation to rule out device erosion, which occurs in 1 in 1000 cases. Patients with ASD and elevated pulmonary vascular resistance require closely monitored management as pulmonary arterial hypertension can progress even after ASD closure. So, patients with ASD and elevated pulmonary vascular resistance require close monitored management as pulmonary arterial hypertension can progress even after ASD closure. This is the figure shows various atrial level shunts. There is superior sinus venosus defect, fossa ovalis defect or ostium secundum defect, inferior sinus venosus defect, coronary sinus defect, confines of true atrial septum, atrioventricular septal defect or ostium primum defect. The figure shows transesophageal echocardiogram in the transverse plane. Figure A shows 2D image of secundum atrial septal defect. Figure B shows color Doppler showing flow through the ASD from the left atrium to the right atrium. Ostium primum atrial septal defect shown by transesophageal echo. Figure A shows this and cardiac magnetic resonance imaging is in figure B. The star mark shows the ostium primum atrial septal defect. Atrioventricular septal defects. Atrioventricular septal defects are a spectrum of lesions that involve deficiencies of the AV septum, often accompanied by anomalies of the atrioventricular valves. Atrioventricular septal defects are a result of failed fusion of the endocardial cushions and comprise up to 5% of congenital heart disease. These include primum ASD, partial or complete AV canal defects. Complete atrioventricular septal defects are characterized by both an atrial and ventricular level defect with a common atrioventricular valve, usually comprised of 5 leaflets. A partial atrioventricular septal defect does not have a VSD component and almost always has a cleft in the anterior mitral valve leaflet. A unique anatomic feature in patients with atrioventricular septal defect is elongation of the LVOT. due to the aortic valve being displaced anteriorly. This results in a scooped out appearance of the ventricular septum and a shortened LV inlet, creating a gooseneck appearance. The severity of the defect is dictated by several factors, including size of the shunt, extent of the atrioventricular valve abnormalities, size discrepancy of the ventricle, and presence of additional anomalies, including alveolar obstruction. Clinical feature: the great majority of patients with atrioventricular septal defect undergo repair in childhood. Older patients with larger atrioventricular septal defects which have not been repaired early in life usually develop irreversible pulmonary vascular disease and Eisenmenger syndrome, precluding complete repair. More commonly, adults with a history of atrioventricular septal defect repair in childhood present with symptoms from residual left atrioventricular valve regurgitation and stenosis, alveolar obstruction, or atrial arrhythmias. The figure shows gadolinium enhanced 3D MR angiogram of a superior type sinus venosus defect. A. Sagittal oblique projection showing the superior vena cava in its length and the defect superior to the true atrial septum. Asterisk. Note the dilated right pulmonary artery RPA in this patient with pulmonary hypertension and long-standing pulmonary overcirculation. In figure V shows axial oblique image demonstrating the distal superior vena cava with the defect at its posterior margin asterisk and communication with the left atrium. 3D reconstruction of gadolinium enhanced MR angiogram in coronal view showing partial anomalous pulmonary venous connection of the right upper pulmonary vein to the superior vena cava. And figure 82.13 shows transesophageal echo image in the near vertical plane showing an unplugged septal occluder device positioned in the secondum ASD. The SVC is to the right of the image. Now, surgical repairs. Indications for surgical intervention of atrioventricular septal defect in adults are similar to those for ASD closure. These include a net left to right shunt QP/QS ratio more than or equal to 1.5:1, pulmonary artery systolic pressure less than 50% systemic, and PVR less than 1/3 systemic. Preoperative cardiac catheterization may be required to assess for pulmonary hypertension. For adults with prior repair, left atrioventricular valve regurgitation is the most common reason for later surgical reintervention. Long-term outcomes and complications. Survival after atrioventricular septal defects repair is good, yet reoperation for left atrioventricular valve disease and alveolar obstruction remains significant. Other late complications include patch dehiscence or residual septal defects and development of complete heart block. Those adults with repaired AVSD and any degree of pulmonary hypertension must be followed closely. Thank you.